Hello, I'm Laura Cheever. I'm the Associate Administrator of the HIV/AIDS Bureau at HRSA, which is the Health Resources and Services Administration. We administer the Ryan-White HIV/AIDS program. I'm here at the U.S. Conference on AIDS with my colleague.
So I'm Dr. Eugene McCray, and I'm with the Centers for Disease Control, and I'm Director for the Division of HIV/AIDS Prevention, and we work very closely with state and local health departments and the community. So Laura, tell me a little bit about what HRSA has been doing at this conference, and some of what you're hearing.
Great. So this has been a really exciting conference for us. NMAC has devoted this conference to really focus on the new presidential initiative around ending the HIV epidemic by 2030 in this country. So what that means for us at HRSA is really we're working in two areas. The first area is HIV care and treatment. Mm-hmm. The Ryan-White program, we're very successful at the people that we see. We serve about half of all the people living with diagnosed HIV in the country. And among people who come into medical care, 86% are virally suppressed, which means they cannot transmit HIV to someone else sexually if they're virally suppressed. So that's great. The challenge we have is that we have about 400,000 people in this country who are out of care, either because they're undiagnosed, we estimate that to be about 150,000, or the 250,000 people that have been diagnosed but aren't currently in medical care. So we need to be doing things differently to reach those people. And we know that our community, people that are out there working in the field, have great ideas about what they want to do. We just haven't had the resources to do it. So with this new funding, we expect an infusion of about $70 million, if Congress gives it to us, into the Ryan-White program. We can do things differently to reach those people out of care. People that are homeless, that have severe substance abuse and mental health issues, we need to be providing services differently to reach them. And with this funding, we'll have the ability to really change up the way we deliver care so we can reach those people. So what do you, in terms of CDC, what's your role and what have you been hearing in this conference?
Sure. So CDC has been, is enrolled in the initiative, is really to work in all of the pillars very closely with HRSA and the other partners. But the main focus of, for us will be in the area of diagnosis. It's really critical that we diagnose that 15% are that 150,000 people or so who are living with HIV and don't know they have it. And to do that, we are planning to do a number of things. We want to build on a lot of our evidence-based programs that we already have in place to make sure we can bring them to scale in the 57 jurisdictions. But we also want to make sure we are doing some innovation to really find people where they are so that we can get everyone tested. So we're looking at expanding testing in clinical settings, making it completely routine. We want to also expand testing in non-clinical setting and make testing more available as point-of-care diagnostics, so we can diagnose people where they are. And then the other areas, we're going to work closely with FDA and manufacturers to make it easier to bring new testing technology to the market so that we can really expand our armamentarium of tests that are available out there in the community. HRSA is the lead for care, for treatment and care, and the one area that we will be working very closely with HRSA on is that when people are diagnosed, we want to make sure those people get linked to care very quickly. So we want to make sure there are good systems in place so that people are immediately referred to HRSA Ryan-White sites, to primary care health centers, etc., to get linked to treatment immediately, ideally the same day. And then the other area is we know that when people are diagnosed that we lose them after diagnosis. So we do a really good job linking people. Around 80-90% of people get linked, but then they fall out of care. And we want to really make sure we are doing what we can to ensure that when people get diagnosed, we are able to retain them in care or re-engage them in care, but ideally re-engaging them into care systems that work for them and not putting them back into the same systems that failed them in the first place. And then the third area that we collaboratively are working on, and Laura, I want you to talk a little bit more about this, is this in the area of preventing acquisition of HIV. That's the protect pillar. And in that pillar PEP, post-exposure prophylaxis, and PrEP, which is pre-exposure prophylaxis, are two biomedical interventions that we want to really make sure we expand. We know that PrEP is very effective in preventing sexual transmission of HIV, as well as preventing transmission from injection drug use, but it's completely underutilized in the community. And there are many challenges with getting PrEP to the people who need it most. And one of the things we're going to be doing is working very closely together to expand access to PrEP, to educate both consumers and provider about PrEP and the advantages of and the prevention benefit of PrEP. And then also there's a need to educate the community in general, especially a community where people who are at risk for HIV live, so that they understand the importance of this effective prevention intervention. So can you tell me a little bit more about what HRSA is going to be doing in this arena?
Yes, so definitely within HRSA we also have the Health Center program, which is also once again a very effective program that really is working with communities in greatest need of healthcare in this country. Through the Community Health Center program, they are going to definitely beef up what they're doing around testing, as you said, getting testing to be a more routine part of care in these communities where we have high rates of HIV. The other piece is around PrEP. So when a patient is diagnosed, is tested for HIV, if they test and they're found to have HIV infection, they can be referred quickly to HIV care and treatment. If they're at high risk and they test negative for HIV, that's great, but we want to make sure that those people that are at high risk are getting onto PrEP. And so the Community Health Center program is going to beef up their ability to deliver PrEP services throughout this country. We're going to focus on 50 counties with the highest rates of HIV in the first 5 years and 7 states that have a substantial rural burden, but then quickly go out to the rest of the country. So the community health centers are going to be working on partly their cultural humility around some of these populations that are at highest need of PrEP, as well as delivering PrEP.
Yeah. And the other thing that I really want to mention is SSPs, our Syringe Services Program. We know that for persons who inject drugs, Syringe Services programs are critical in preventing both transmission of HIV, but also transmission of hepatitis, and especially hepatitis C, which is a big problem in the U.S. And we want to make sure we are supporting comprehensive Syringe Services programs so that for people who inject drugs, they can have access to clean needles and syringes as well, and other injection material, and get referred for appropriate services like mental health service, substance abuse treatment services, like MAT, etc. And we know that SSPs are very effective, and we know that the evidence, 30 years of evidence have shown us that SSP does not increase drug use, it does not increase crime. And we know that if someone is able to get into SSP and refer to medically assisted treatment, they can get off drugs, drugs. So SSPs are a critical part of what we're doing.
Yeah, and the Community Health Center program in the last couple of years has had a huge investments that have been very successful in increasing the ability of a community health center to integrate mental health and substance abuse services. Because one of the big issues we've heard here is around stigma. We know that stigma is a huge barrier to what we need to do in many of these communities. And so by better integrating services, we think that'll help decrease stigma. The other thing is we are really looking to community to help communities help us figure out what they need. This plan really needs to be centered on community. Can you talk about how we're doing that?
Yes. We're doing it, but we're just really at the beginning of the process. There have been a number of what I'm calling high-level community engagement sessions that have involved that our leaders, Laura and Dr. Cheever and my director, have been engaged in, where we've brought in health leaders, we've brought in politicians, etc., because it's really important for this initiative that we build the political will and support by the policymakers in those communities to do this work. But more importantly, we really need to build the support and engage the community that is affected and living with HIV. And so there's another level of engagement that we have done where actually the programs that we'll be implementing and working with the community and the health departments to implement this, CDC, HRSA, SAMHSA, etc. We've done a limited number of community engagement where we've had members of the community organize listening sessions, so that we've been able to listen to the concerns of the community and then take that back and incorporate it into our planning. Now what's going to be happening and moving forward, and some of this is happening already, is we will be providing funding to support planning in each of these jurisdictions. And this planning really needs to be planning that's targeted to those phase one, those 57 jurisdictions that are part of the initiative, to really make sure there's substantive, what we call substantive community engagement in the planning, but also we want them to think clearly about how they will engage the community in implementation as well as evaluation of some of the work that will be done. So we know that in order to be successful in this initiative, we have to have real engagement from the community. And when we talk about community, it will vary a bit from place to place, but we're talking about people with HIV, we're talking about people at risk for HIV, we're talking about clinicians, we're talking about community health workers, faith-based communities, etc. So the community is broad, and it really needs to, when they do the planning, it really needs to reflect the members of that community, and especially Native people, because I don't want to leave them out. Thank you.
Yeah, and I do think that is so important. We heard at this meeting loud and clear, it's not just about engaging community, but really helping to foster community mobilization.
Right.
So we need to figure out how to do that. Within HRSA, we've been working for the last several years. We have in our law that community needs to be at the table in the planning that happens at the city level. But we need to make sure that we have given a community members some of the capacity to engage in those more complicated planning discussions as people are talking about incidence and prevalence, and being ready to sit at that table and actively engage in a meaningful way. So we've had the Building Leaders of Color, the Block Initiative. We funded that. We'll continue to fund that in the future. We're going to translate that into Spanish to really expand our reach there. We've done work with community health workers, and in the coming years, we will continue to really invest in those training and capacity building and developmental opportunities for people with HIV to help them be better prepared to engage in that kind of discussion.
The other thing that I wanted to mention is workforce. One of the things that we've been hearing is that from the community is that as we are thinking about ending the epidemic, we have to really be intentional about building the workforce that will be required to do this. And so when we think about workforce, we think about the public health workforce, which is going to be critical because we're going to be diagnosing a lot more people. We're going to be getting a lot more people into treatment. So the public health workforce, the clinical workforce, but more importantly, the community workforce, because the community to be effectively engaged has to be employed and working to help support their community and others in getting into care, getting tested, etc. So the community workforce is a major component of what we'll be looking at as we go forward.
Yeah, so within HRSA, we've had about 70 opportunities to present to communities and to organizations in the past year, and that's definitely one of the things that we have heard, that we need to figure out what we can do. If we're trying to reach people we haven't reached before, we need to be using new methods. So we know that engaging peers and navigators and people that are from the community, that understand the community, are essential to that. So we're really excited about that. We are going to have a listening session tomorrow for people that are here at USCA, 9 a.m. HRSA listening session. So please join us there, because we really do want to hear from you. As we're closing, because I think we both need to be getting to our next session, can you tell me some of the activities that are going to be happening in the near future from CDC? Sure.
So one of the things that I briefly mentioned is a funding opportunity that we released early in June that will be funded by the end of this month. And it's really funds that will be going to the jurisdictions to help them with the community planning so that they can then develop plans. So so that money will be awarded by the end of September, and September 30th will be the start date. And between now and December, and even after December, we are expecting the jurisdictions to work very closely with the community to do planning. So that's one thing. The second thing that is going to be happening is we are in the process of developing another funding opportunity, which is what we're calling an implementation NOFO, meaning a notice of funding opportunity, which means that we want to really have the community go on and begin to develop their plans and have a draft plan, so that when the money comes in 2020, they're ready to hit the ground running, at least with what they consider to be their highest priority activities. And so we expect the planning process to be an iterative process. That we'll have draft plans by the end. We hope to have draft plans by the end of the year, but we expect that there will be ongoing planning throughout 2020 to really make sure they are capturing and engaging all of the community that needs to be engaged.
Yeah, so from HRSA, we have our Notice of the Funding Opportunities, NOFOs, out on the street. One of them is to directly fund the cities, the heavily impacted cities that we're trying to target, as well as to the focus states. We've heard from a couple of the cities that they think that's just a lot of work and they're not sure they're going to get it done. And I would encourage community to encourage your representatives to make sure that they apply for this money. Right this year we have $70 million, which compared to the $2.3 billion invested in Ryan White is not a lot, but it's a 5-year commitment, and I think in future years the amount of funding available will increase dramatically. So it's really important people apply this year to get into that 5-year strategy. So I encourage people. We're also, those are available right now for people to apply. We have technical assistance. We want to fund someone at the national level to help provide technical assistance and coordination across the program. So I would encourage people to look at what those opportunities are that are on the street. The AIDS education and training centers are all going to get funded to do some of this work as well. And the community health centers, we're going to be funding between 150 and 180 community health centers in the first year in these focused jurisdictions to get PrEP up and going. So there's lots of opportunities coming in the coming weeks.
Right. And then the last thing I wanted to say is, well, there's several things I want to say, but well, one is I would be remiss to not mention to you that we, if you want to learn more about what CDC is doing to support the End the Epidemic Initiative, I would encourage you to go to our website. It's called cdc.gov/end-HIV. And that has a lot of information there. Also, as people are beginning to plan and they're thinking about the kinds of communication or awareness campaigns that they need to have out there, I would encourage you also to go to another website. HIV.gov is a wonderful resource, but CDC has a website, cdc.gov/stop-HIV-together. And it has a number of resources that are available for each of that could help you in planning and thinking about each of the pillars of the initiative. And we have for those of you who are listening here at the conference, we have a booth 514, where many of these resources are present.
Great, thanks. So in closing, I think I would say that in this meeting, we've clearly seen from community that people are very engaged. There's a lot of enthusiasm and forward momentum around ending the HIV epidemic. It's a lot of work, and we've heard that too. People are just trying to take a deep breath and figure out how they're going to get it done, but there will be, we hope, if Congress gives it to us, funding to get this work done. And we know we have what it takes. We have the science. We know that people have the ideas. They have the innovations in the community that we can now apply.
Yeah, and the only thing I will add is that I think Dr. Cheever is absolutely correct. There's anxiety out there about how all this is going to get done. But there's a lot of support available. I mean, Dr. Cheever has talked about a lot of the capacity building assistance that they can provide, but also at CDC, for many of our grantees and others, we have a capacity building assistance program that will be empowered and ready to go. We also will be funding another large agency that will be focused primarily on supporting the jurisdictions to help with the planning. And then, of course, we have resources within CDC, our own staff, that will be ready and available to help support planning and so forth. And then when our NOFOs, when our funding opportunity is eventually released, we will have a number of webinars, and HRSA and CDC are already talking about having some joint webinars to really answer questions that people may have about the planning and about some of the things that they're thinking about doing. So, thank you.
Thank you so much for listening today. Thanks.